Hello, my name is Yejun Hong. I'm a medical student in the University of Calgary, and our team is here to explain Alzheimer's disease as a link between ophthalmology and neurology. The eye is a sensory organ that is very closely linked to the nervous system. It is located very close to the brain, and part of the eye, the retina, has a neural layer for detecting light stimulation. The eye itself is innervated by 4 cranial nerves out of 12, and there are a lot of diseases that involve both the eyes and the brain. One of those is the Alzheimer's disease, which is neurodegenerative dementia related to neurofibrillary tangles, tauopathies, and ophthalmic complications as well. Alzheimer's is one within the spectrum of dementia that has characteristic neurodegenerative features and global brain atrophy. Global includes the frontal, parietal, and temporal lobes. The picture below on the right shows the coronal view of the brain, and you can see that every aspect of the brain begins to shrink throughout the progression of Alzheimer's disease. The optic nerve is responsible for gathering light information from the eyes, interpreting them as electrical signals, and bringing them to the brain, all the way to the occipital lobe. This is cranial nerve number 2. And here are some of the anatomy of the eyes that are related to the optic nerve. The optic disc, which can be observed on the fundus exam, is the point of exit for all the ganglion cell axons, which are located within the retinal layer. Optic nerve and sheath, as you can see in the diagram on the bottom left, continues after exiting the posterior part of the eye. Tenon's capsule is a thin fascial sheath that surrounds the eyeball and separates it from the orbital fat so it can move as freely as possible. And the overall anatomy, including the fat and the extraocular muscles, as well as the vessels, follow along the orbital cone. This is named as such because the overall anatomy looks like a cone, the circular base being the location of the eye, and gradually becoming narrower as you follow along into the head to the optic canal. There are a few hypotheses for the pathophysiology of Alzheimer's disease. This disease is still mysterious in terms of research, and further elucidation in the labs and the clinic is required to better understand Alzheimer's. One of those theories, called amyloid hypothesis, suggests that accumulation of amyloid beta plaques in the brain contributes to Alzheimer's disease. This theory is supported by the fact that APP gene, or amyloid precursor protein gene, is linked to the Alzheimer's disease in a way that a lot of Alzheimer's patients have mutations in those genes. Diffuse amyloid plaques also become neurofibrillary tangles in trisomy 21, or Down syndrome. Lastly, the amyloid hypothesis has been in contention with the tau hypothesis, and the support for amyloid is that mutation in tau genes do not cause Alzheimer's disease. However, the fact remains that Alzheimer's disease is multifactorial, involving all of genetics, environmental amyloid beta, and tau pathologies to come together and form an amalgamation of patients' circumstances that lead to Alzheimer's disease. Each of the factors gradually increase the risk of the individual to Alzheimer's. And this is probably the most widely accepted model that shows the cause of Alzheimer's disease in today's medical society. The risk factors of Alzheimer's disease include family history of dementia. This is where the genetic factor plays a role. The APP gene in chromosome 21, PS1 gene in 14, PS2 gene in number 1, as well as having trisomy 21 can predispose an individual of having an Alzheimer's disease. And because it's genetics, if any individual in the family has that, the more directly related that individual is to you, the higher risk you'll have of developing this disease. If the individual has Down syndrome, this may directly mutate the beta amyloid precursor gene on chromosome 21, or because this is a trisomy, there's an extra copy of the gene. So the production of these proteins can become abnormal in rate. And more of the other environmental factors and also alteration of epigenetics. As an individual becomes older, the risk for Alzheimer's disease goes up. When diagnosing Alzheimer's disease, this is mainly done through pathology-based diagnosis. There are some cognition-based tests, but they are by no means diagnostic. There are a lot of signs and symptoms that can be observed in Alzheimer's disease, as the entire mind and the synaptic networks become destabilized. We have separated these constellations into mild, moderate, and severe phase. In the mild phase, the individual may experience memory loss and poor judgment. Even in areas they have navigated themselves for years, they may wander and get lost, and mood and personality changes may begin when the frontal lobe is affected. Anxiety, aggression, and more effort and time to perform the same everyday tasks can also be observed. In the moderate phase, the individual may become more impulsive and have inappropriate behaviors and let out episodes of anger outbursts. Restlessness, agitation, hallucinations, and delusions are some hyperactive signs observed in moderate phase. And then finally, in severe phase, the autonomous functions of the brain starts getting affected as well, such as dysphagia, inability to swallow, and incontinence, where urine and defecation can occur without conscious command. Eyes, being located so close and linked very intricately with the brain, is not an exception to changes observed in Alzheimer's disease. There is decreased visual acuity, as spatial relationships may be impaired, and they also, on observation of the fundus, have optic nerve abnormalities. Differential diagnosis to an observation of Alzheimer's disease-like presentation includes cerebrovascular accidents like stroke and other neurodegenerative diseases along the spectrum of dementia, such as Lewy body disease. History and physical exams of with this patient may include interviews with the patient with regards to feelings, any changes in the pattern of behaviors that they've noticed, meals, whether they're eating more or less than before, or having a sudden change in preferences of food, as well as the memory deficits that they have been noticing for a past defined lengths of time. It would also be valuable to have a separate interview with the family members about how the patient is coping and how they have been going through this new deficit in the patient, and if they are working together to find a strategy to adapt. Cognitive testing, such as MoCA, is a way to objectify cognitive impairments, and efferent testing for the eyes, including saccades and extraocular movements, will tell you if the cranial nerves are intact. Fundus exam and OCT to find out about the changes in the fundus and the optic nerve area would be prudent as well. Investigations with someone with Alzheimer's disease may include amyloid imaging, lumbar puncture with the analysis of amyloid beta protein, and MRI of the head to look for brain atrophy. Treatment of Alzheimer's disease should be individualized. So identify the caregiver and assess the risk in either in their homes, of the navigations around their homes, seeing if they need walking aids, as well as looking into activities of daily living. Pharmacotherapy may include cholinesterase inhibitors that increase acetylcholine levels, and also looking into NMDA receptor antagonist, which protects against glutamate excitotoxicity. Lastly, vitamin E, which is an antioxidant, 2,000 units a day, may prevent further damage to the brain. Prognosis of Alzheimer's disease has wide variation, and the remaining life of the patient with Alzheimer's disease may vary from 3 to more than 20 years post-diagnosis. So here are the links between ophthalmology and neurology, as well as the comprehensive summary of everything we've talked about in this presentation. And here are the references from which we got the information to put together this PowerPoint. Thank you for watching this video.